So perhaps if I could just play it. This is actually what I want from you as a team to design for me. This is a lady who is sitting on a couch. She's pregnant.
Très rapide et très facile.
Okay, so who's going to do that? Now let's go into the simpler stuff. So basically, I thought perhaps 10 or 20 years ago, if someone said to you, there's going to be a woman in your car telling you to turn left, telling you to turn right, telling you that your petrol is low, or do you feel like stopping for something, would you have thought that that would be reasonable? So perhaps our children or the next decade to come, or hopefully much, much shorter timeline than that, we will create something that is somewhat of an analogy with that in mind. So I also wanted to start by acknowledgement of country. We recognize the traditional custodians of the land on which we live and work, and basically pay our respects to elders past, present, and emerging. So I thought we would start with the background to what is a global picture of maternity care in Australia. So we birth 300,000 babies in Australia per year. And generally speaking, compared to OECD countries, we actually do quite well, both on the maternal context and from a neonatal lens. However, when we look at finer analysis of that data, there is certainly a lot of potential to improve, particularly from the stillbirth point of view. So I've sort of zoned into that as one angle in this presentation. So we have basically a stillborn rate, which is about 7 in 1,000 births. So that means that while every maternity clinician and general, managers and the whole bigger team want every woman to leave our doors with a happy, healthy baby in her arms, we know that that doesn't always happen. And this is only talking about loss from a death point of view or mortality point of view. We obviously have babies that are born that potentially, looking back, could there have been things that were avoidable or things that we could have supported with to have had a better outcome than we have ended up with. So again, in the context of most women do well, most babies do really well. However, there is certainly room for improvement. And I see AI as perhaps something that could partner with us or could add a platform of safety to us that would then enhance the decision making that we currently use or do. So there are certain risk factors. And to the left-hand side of my slide is an initiative that's been recently launched in Victoria, which is called the Safer Baby Bundle. So that is actually combining things like, is this baby a bit smaller? Is this mom vigilant about the fetal movements that she's having? Is she smoking? Has she been encouraged to consider to stop smoking? And so basically it ties in a combination of both the mum and clinician-based responses. Particularly, another simple thing is around sleeping on your back. So when we look at studies, particularly when we look at the journeys of the women who have actually lost babies, we find that there is an association there as well. So again, when I was asked to talk about challenges, I went through some very hi-fi challenges in my mind. I thought, what about robotic surgery? And maybe there's a mass there and we can have a fancy, instrument at the top, and that will tell us inside the mass is bowel, and so the surgeon can continue cutting, or maybe it will tell us sonographically that it's just fluid, and, all those high-end stuff. But then I came back to maybe the future of AI is in your everyday woman's journey. Maybe that is where we need the support. We need, because we know that there's a lot of fragmentation of care in Australia in terms of, we know, well, I don't know how to put this tactfully, but the state and the federal, angles of how they interface into the health for the clinician at the coalface. So how do we integrate that journey better using AI as a platform? So like I mentioned earlier, ideal situation is that we want every parent prepared. We know that 50% of pregnancies in Australia are unplanned. So can the journey start from there? Can this be so again, I do apologize up front. My model is very vast. And again, the reason why I've come into that is that I'm coming in as a mere clinician So I'm saying this is what we experience at the coalface. Whereas what we often find is we get an app for this, or we get everything is working in parallel, but no one has really thought through the big picture of, this is a woman, she is going to think of falling pregnant, or she's going to find out she's pregnant, then she's going to be in early pregnancy. What are the clinical interfaces that she's going to have to negotiate? And then she's going to have to come up to the birth angle, and then she's going to go back into the community to her GP to continue that longitudinal care that we basically all go through. So again, that is just going into from chronologically from the preconception to the early pregnancy phase. I just wanted to mention that maternity, like probably every other part of medicine, is a very political space. So there are different clinicians, and I think the way of the future is collaborative care and creating functional teams. And again, that is something in which AI, I think, could really be the platform, because a lot of, although they might be different birth philosophies, and we know, I'm going to be very open about this, they in the same clinical context, you might have a person that wants to have a very natural birth. And at the same time, you might have a clinician that's just saying, sign here, when can I take you to theater? So, and at the center of that is the woman and what she wants and what her birth philosophy is. So apart from all the complexities of the decision making, we now have all of that in the background from different groups that are providing care for women in this country. So like I've mentioned, when someone falls pregnant, they could be triaged to obstetric care, to a midwifery clinic, to a midwifery group practice, or a medical obstetric clinic, or a shared clinic with a GP, depending on what the risk status or what the preference of that patient is. And these clinics, sometimes they can be quite significant communication gaps based on a lack of a robust platform that communicates. So like Haroon, I've chosen to actually use a patient journey to try and bring the issues that we feel at the coalface are problems for us. So this is Anna, who is 32 weeks pregnant. She's already coming into with anxiety. She's in her second pregnancy. She had a heavy bleed last time, so she's got that trauma from her previous pregnancy. She also reports that her baby's not moving as well this particular pregnancy. So what I was trying to put there the slide is actually quite small and it's shrunk. It's hard to tell all the risk factors, but there are a number of risk factors there. And again, it's that whole context between machine learning and human learning in terms of how many of those risk factors does she have? How well are we able to quantify this woman's risk? So at the end of the day, is there a potential for us to quantify risk better than the human mind? And how optimistic is it that, how many patients will I see in my lifetime? So will the machine that will have access to millions of data sets, if that's the base of what we choose, will that provide better decision support for me at that phase? So in my mind, I thought perhaps, could there be a bracelet that the woman could wear? So if she falls and becomes unconscious in a shopping center, everyone has immediate access to what her record has been. Could there be a code that is created for every pregnancy? So then that integrates her care no matter of where she goes. And I know I'm talking very simplistically now in terms of just an EMR angle or the access of a patient to her own information. But I think that is certainly a very, very critical problem for us and creates a lot of clinician inefficiency. And would there be a magical way that all the ultrasounds and the radiology and the pathology that this woman has had that would be accessible in that app or bracelet or whatever, far better than me in terms of, or a chip in the ear. But yeah, could that then sort of stop her coming to our service and us asking, where did you get the ultrasound done? Oh, it was the ultrasound service opposite the petrol pump in that. Oh, okay, now let's get the number. Now let's get it faxed across. This is what we face daily at the coalface. And so the other thing that got me thinking was, I do run national exams. I coordinate the DRANSCOG, which is a GP diploma exam for women's health. And we run this out of University of Adelaide Simulation Center. And basically, because I run this exam for years previously in a very manual-based method, and now we have this purpose-built sim center, I find that the difference between when the candidates are lined up and they just log on and that code goes in and they enter the service. It just runs to perfection. So that got me thinking, should a woman have a code? Should she code and enter the clinic? So we've got the similar sort of clinic set up, and we've got a similar birthing unit set up. We've got 8 rooms. Should that code carry through to when she goes to birth? And should she, and again, I'm asking, I'm not saying this is the way of the future, but should there be a social robot that is adding on to the care? And does that have a profile that she's journeying with? The single thing in maternity care that has been shown to particularly improve outcome is continuity of carer. So that has been shown through in the midwifery group practice or in a private obstetric model or in the GP model. Women don't want to come and tell their story again to a new clinician and start that whole journey again. They want that continuity of care. So could there be some potential to add on after the clinician has seen perhaps this could reinforce some information? So again, studies have shown that when we have a consult with patients, the amount of information they retain is very variable. And I have often been in a situation where I'm told, oh, there's so-and-so waiting, her nuchal is abnormal. She said nobody told her that it could come back abnormal. I'm like, oh, consult this woman before this test. And why am I at the end phase of this? But then when you speak to the general practitioner, they're like, oh, of course, I tell everybody about the test. So then somewhere in that equation, the processing or the absorption of that information has been flawed, because at the end of the day, the patient is saying, I don't understand this. So is there a potential for us to then add on to our clinical consult and say, hey, we're sending you this information. It's going to be provided in a very friendly way, and it's going to be provided in a very patient based system. Up there is the yellow card. That is our current national way of communicating between practitioners. I will tell you that I have patients coming with coffee stains on that card. I have vomit of the older child on that card. I've had lots of joys with that card. And then there's the scribbles and the half-written scribbles between different people that they've seen. So I've had lots of joys with that card. So we're really looking forward to something replacing that as a platform for us to communicate with. On the left-hand side is just a map of the journey. You'll notice I have mother-in-law in there as well. But basically the different in the real world, what are the influences that women have during their journey? It's really not as simple as just checking, but they have so much access to information, access to blogs, and that does not do wonders for Anna's anxiety. I also led Passing the Baton project, which is a localized project in our hospital, which was around handover. So we've been talking about the patient absorbing information or the woman and her family absorbing information, processing, but what about the team and the connection between the team that is in the hospital, not just the team to the GP or the team to the external providers? It's actually within the hospital as well. How do we improve that around, put the woman at the center of the care that we deliver? These are just some slides that highlight what work is already happening in this space. So we have the digital agency working on the pregnancy record, handheld record, to hopefully create an electronic version of that, which is almost at the proof of concept phase. We have the above slide shows basically the points. So 15 to 20 visits during a low-risk pregnancy are expected. So whether we consider, that includes the community visits and the whole snapshot view of where she will journey through. We also have certain private providers like K2 and GE doing some space in the ultrasound world and in the CTG, which is our way of assessing in labor. So back to Anna. So Anna now goes on to different blogs and basically has these different options of reading about pregnancy, only because we haven't actually proactively led the discussion by saying, here is the information you need to read. Yes, after that, if you want to, feel free. Obviously, that's everyone's individual decision to do what they want to do. But mostly, the women want that clear, concise, evidence-based information to be provided to them consistently in different languages. So is there potential for us to do away with leaflets that they might just throw or might not actually have the retention for? Again, is there a more friendly way and consistent way to give information. We've had a lot of discussion around ethics and the medical legal angles. Who is responsible if we turn to an AI and then basically take a clinical decision, especially when there's conflict, because we do already have an AI version in the labor ward context, and this is called Infant. And Infant is a way of analyzing the unborn baby's CTGs. So in England, 47,000 women journeys were mapped. And what they found that so there's a basal level of guardian, which just helps us alert. For example, is more yes, no, in terms of is the variability normal or if different aspects of that is normal. Whereas the infant system actually comes out and gives opinions that this is what should be done, or takes a little bit into other risk factors into note. And in that study, unfortunately, it didn't show a significant benefit at all in outcomes, particularly from using the infant as an additional to the baseline of the guardian. But to be honest, the comparison wasn't with the human eye and wasn't with another hospital where you couldn't have that potential for machine learning that would then keep, for example, if I'm not that good at CTG interpretation and the machine tells me, oh, well, this is how you should, this is what this person's care should be, then for my next patient, I actually am a bit more primed, and that has actually helped educate me, assuming that is the right advice that I'm being given by the machine. So I think there was an element of that as well. There was a criticism that perhaps we were not measuring for the effect as well as we should have. But anyway, I have to be very upfront that it didn't actually show a significant benefit in that context. So in all of those things that I've tried to muddle through, I basically wanted to say probably the one that as a team you might be more attracted to is the ability to process diagnostic individualized risk. So based on ultrasound results or clinical factors. So in her journey, for example, going back to the stillborn case that I started with, so, for example, if she's from a subcontinent region, that does increase her risk. So as a clinician, maybe if the machine said to us, hey, hang on, she's got this blood pressure, which is not really 140/90, so you technically wouldn't label her, but it is 140/88. So can it actually quantify for us more the risk factors than we might be doing in a clinical sense? So I guess I'm asking that to the group. And the AI I mentioned in terms of the ultrasound side, again, I find as a clinician, you might have a woman with a risk factor, or she's got a small baby, and so she's having serial scans, the way different clinicians are going to interpret that. And at the end of the day, we're trying to say, when is that fine balance reached when we think that this woman should be offered a delivery? So can this help us quantify it better than the human mind would, looking at millions of ultrasounds and then saying, hey, maybe at 37 weeks, we really need to quit because we're ahead and let us deliver this woman? Or can it actually, can it bring that into the equation better than the human mind can? So I think ultrasound is certainly a way, and particularly serial ultrasounds are a way where we might be able to create a more individualized pregnancy risk for every woman, as opposed to a general philosophy that this is what this does. So another thing in the general space is basically the humanized robots. So again, I think there's been a lot of reservation from clinicians and from psychologists, starting from, they're not going to take our jobs, are they? Well, there's 7 million people on the planet. Do we really need a machine to be offering compassionate care? Why shouldn't the clinicians be doing it? So I'm coming back again and again that this is not replacing the clinician interaction. This is really an additional add-on. So again, I was just trying to say, look, what is already out there, because the PHNs are already exploring this. Please tell me time-wise, is it okay, or am I going over? 2 minutes, okay, thank you. Yeah, and so again, so these are the concerns for the model that I've already alluded to, most of them. In terms of the other worry that when I spoke to my junior doctors, who I find are actually a very good resource whenever there's anything to discuss, because again, I don't mean to be ageist, but they're a bit younger and they also are usually more IT savvy than myself. So I do get a lot of wealth of experience from them and information from them. So they were saying, what about de-skilling? So if the machine's telling us how to interpret the ultrasound ultrasound and how the machine is telling us how to interpret the CTG hypothetically, then what are we using our neurons for? And I said, well, how many of you have a book in your car and are you using the book to find how to go to the city? So, and they go, no, none of us. So I said, well, that's just, maybe that is just a perspective, and maybe that is just the way the times are going to change, and maybe that is the way we need to view it, that if the machine does it better and chose to do it better in terms of quantifying an individualized risk for the woman, maybe that will give you time in that 15 minutes to talk to her and to provide that compassionate care that you're so worried the machine is going to provide. Why not let the machine do what it does quite well in terms of being able to assess that? So that was a direct conversation that I've had. I'm just saying, sharing with you. And then, of course, around the cost-related issues and the uncertainty around new information and the paranoia around sharing data and what people want to do with the data. So from a clinician, from a consumer perspective, there's obviously, we're very well aware of some of the scandals that have occurred and how much anxiety they could be in terms of who's going to look at my data. And sometimes I worry that the patients that need the most scrutiny in terms of perhaps they might have a journey that we can medically help them most with might be the ones that actually don't want to share their information as much. So everybody loves a baby. And I just wanted to mention that I'm basically trying to start a private practice very shortly, and I've bought a home that's going through council approval for a DA for a medical center for women. And basically, I was just saying that in my own personal journey, I've tried to put the woman at the center of all the planning. I've not looked through the financial lens, and I might probably regret this. And if I present next year, I'll be like, "Ooh, that didn't quite work." But I truly have tried to say, look, what are the touch points at which this woman might need the extended team? Would she benefit from perhaps a session from the psychiatrist, who are friendly psychiatrists, happy to come into one of the rooms and give us a session every second week? Would she benefit from, allied help, the physio actually seeing her rather than me saying, oh, you go and get an ultrasound, then come back to me and then we'll send you to the hospital. So I'm trying and just see it through the lens of the patient and the family. But to make that work well, again, it comes back to, can technology empower us? Because we have all these great ideas, but I think that they will only truly come together if we are able to use technology in a positive and in a functional way. Thank you for your attention.